So now we are going to move to the malignant metastatic tumors and see how we can treat those patients. These are my disclosures. The problem is that there are many factors that influence treatment decision. As you just heard, tumor differentiation and grade, well differentiated or poorly differentiated, G1, G2, G3. Where is the primary tumor? Here we will speak about the pancreas, but of course the treatment is not the same for the neuroendocrine tumors from the small bowel. Is there a hormonal syndrome? What is the tumor stage? And where are the metastases? Are they in the liver, almost always, but also in the bone, in the peritoneum? What is the percentage of liver involvement? That is very important also. Is there, as in 80% or 85% of the cases, a presence of somatostatin receptor, which will be evidenced much better with gallium DOTA-PET than with ultrascan, but both techniques can show the somatostatin receptor expression. What is the evolutive slope? What is the tumor growth rate? These are tumors that are most of the time very slowly growing, and this should be also taken into account. What is the patient background? Many people have advanced age, a personal history, frailty. What is the aim of the treatment? Is it the quality of life of the patient? This should be taken into consideration. And what is the anticipable long-term toxicity, which can be cumulative between different treatments? And finally, what is the main treatment objective? Is it surgery, which is possible but rarely in patients with metastatic disease? Is it symptom control? Is it only quality of life or prolonging overall survival? And of course, last but not least, what treatments are available at the place you are working? Surgery, is PRRT peptide receptor radionuclide treatment available? Or this is very important. Do you have access to TAE, transarterial embolization, chemoembolization, or spheres, SIRT? Of course, all treatments are not available everywhere. And if you look at this kind of axis, which goes from up, less aggressive, to down, more aggressive treatment and tumors, of course, once anti-secretory treatment is installed, if necessary, surgery should be considered first because it's the only option to cure the patient even at the metastatic stage. But if everything seems resectable, slow growing, with a low Ki-67 below 10%, we consider surgery for those patients, but these are not the majority. The second step in almost all patients, at least if the disease is not too much aggressive, are somatostatin analogs. I will not spend too much time on this because it's well known, but of course this is a treatment that is simple, non-toxic, and is able to slow down the evolution of non-aggressive NETs. But once these somatostatin analogs have failed, what should we do? And as you can see on the bottom, we have many treatment options, which make, by the way, the interest of this disease, because we have to choose between local treatments in the liver, systemic treatments, targeted treatments, and PRRT. Just one slide about somatostatin analogs. The famous Clarinet trial we performed with others in 2014, which was the first trial, randomized trial, to show that in patients with pancreatic lesions, there was a huge benefit using lanreotide 120 milligrams every 28 days, and compared to placebo, this resulted in a triple progression-free survival as compared to the placebo arm. After 2 years, 62% of the patients had still stable disease, while this was the case in only 22% of the patients in the placebo arm. So clearly, somatostatin analogs is the first-line treatment in patients in whom the disease is not that aggressive. What do we have apart from the somatostatin analogs? We have systemic chemotherapy in neuroendocrine carcinomas, poorly differentiated, or neuroendocrine tumors. And here we have alkylating-based treatments or oxaliplatin-based. We have, let's say, two available targeted treatments, one mTOR inhibitor and one tyrosine kinase inhibitor, and we have liver-directed treatments. Next, neuroendocrine carcinomas, G3, it's all about chemotherapy. Few patients have localized disease amenable to radical surgery with or without perioperative chemotherapy. But by the way, they are metastatic in most cases and they need urgent chemotherapy. The problem we have here, this is very aggressive disease and nothing has changed still the 90s from the studies from Charles Mertel, which were confirmed by Emmanuel Mitry in France, using the etoposide platinum combination, either cisplatinum or carboplatinum. And as you can see, you get quite a high rate of objective response in red, 67 or a little bit less in some other studies. But the problem you have is that those responses are very short-lasting, 8-9 months, and the median overall survival is very short. So you have some effectiveness of chemotherapy, but for a limited period of time. And to be honest, there is no real convincing second-line option, even, of course, if we try different combinations. Let's come to well-differentiated neuroendocrine tumors of the pancreas, and here things are really different. The oldest combination with some evidence of efficacy is the combination of streptozotocin and doxorubicin. Most retrospective studies, few prospective studies in this field, have shown that the response rate is around 50%, lasting for 14 to 18 months. The problem is that, as you know very well, doxorubicin has some important toxicity, mainly cardiac toxicity, and is not really used anymore. We do prefer to use strep plus 5-FU, which gives almost the same response rate, and provided you monitor carefully the kidney toxicity, is much better tolerated. What is more interesting is the coming in the field of temozolomide, which can be combined with capecitabine. And as you can see on those curves, this treatment, and especially the combination of the two drugs, is more effective than temozolomide alone, with progression-free survival of almost 2 years, which is very high. And there is an intravenous counterpart because temozolomide and capecitabine are oral drugs, but you can also use Detisen and 5-FU, and it seems that this intravenous counterpart could be even more effective, as we showed, than the oral regimen. Finally, Folfox and Gemox, that you can use in other tumor types, as you know, can also be effective in patients with neuroendocrine pancreatic tumors with 30 to 40% response rate and 10 to 18 month duration, but this with lower level of evidence. What is very interesting with temozolomide and 5-FU is that we do have a biomarker for efficacy. This is an enzyme called MGMT, methylguanine methyltransferase, which is a protein that is responsible for inactivation of temozolomide and repairs the DNA damage which is provoked by chemotherapy. This is very interesting because the more MGMT you will have in the tumor, the less effective the chemotherapy will be. And as you can see, there is an MGMT deficiency, which is of good, of course, prognosis, in more than half of the patient. And what we were able to show is that the PFS of the patient treated with temozolomide depends on MGMT expression. And the figures are evident. You have a median PFS of 27 months with the CAPTEM regimen if MGMT is low, versus only 16 months in those patients who have high MGMT. In our department, we make a condition for use of temozolomide capecitabine or Detesin 5-FU. The expression, the low expression of MGMT in the tumor is a condition for use of those chemotherapy. While oxaliplatin efficacy is not influenced by MGMT status. As well known, pancreatic and all neuroendocrine tumors, well differentiated, are highly vascularized, and this has led the pathway of using anti-angiogenic drugs to inhibit vessel formation, and bevacizumab, of course, Avastin, is one of those drugs. And in a study performed with Gustave Roussy some years ago, we showed that, indeed, we could achieve long progression-free survival and high response rate in combining the classical 5-FU streptozotocin regimen with bevacizumab, and the same was true with FOLFOX. So, when and how should we use chemotherapy for patients with advanced pancreatic neuroendocrine tumors? First line, if the disease is aggressive, high Ki-67, symptomatic patients, importantly in their involvement, over 50%, and in second line, as I said at the beginning, in the patients who have more quiet disease after failure of somatostatin analogs. Those combinations are recommending 5-FU strep, temozolomide capecitabine, or the IV counterpart. The alternatives with less level of evidence are the oxaliplatin-based combinations. The choice of chemotherapy should probably follow MGMT status as determined inside the tumor. The combination with bevacizumab should be also considered. The problem of the duration of the treatment is really important. We used to, in many patients, do that for 6 months, and then if the disease is stabilized or even has shrinked, we stop treatment until progression, and we can discuss a maintenance treatment with somatostatin analogs. Let's come more quickly to targeted treatments, and as I mentioned, 2 of them are available. The first one is everolimus. Everolimus is inhibiting the mTOR pathway and is commercialized under the name of Afinitor, and sunitinib is a multikinase, tyrosine kinase inhibitor. Many others are more or less ready for commercialization or still under investigation, such as cabozantinib, for example. Everolimus is effective in patients with pancreatic neuroendocrine tumors. It's an oral drug. It's 10 milligram per day pill. And the RADIANT-3 study, which is the biggest study ever performed in patients with pancreatic neuroendocrine tumors, more than 400 patients included, with a placebo arm, everolimus arm. As you can see on the upper right curves, that it is definitely effective. The problem we have is that, as you can see, this efficacy is not so high. There is a difference of 6 months between the placebo, 4.6 months of progression-free survival, and everolimus only 11 months. So it is effective, but not that much. The objective response rate is extremely low, but what you can expect is a 78% of disease control, so non-progression. It's very interesting in the peculiar case of patients with metastatic insulinomas, because one side effect of everolimus is hyperglycemia. So patients with hypoglycemia from insulinomas have very good effect of everolimus on their symptoms. The problem is it's a drug which is not so simple to use. There are some precautions, especially in patients with diabetes or cirrhosis. The list of side effects is quite impressive, especially stomatitis, cutaneous rash, diarrhea, and can be very painful for the patient, or even very severe, because you can have also lung problems, lung pneumonias, and in some cases, those lung pneumonias have been fatal. So, limited efficacy, however, some efficacy, but limited, and some problems which make the patient, let's say, in less good general condition. And of course, patients who are with their disease in good general condition do not like a drug that put them in with some asthenia or stomatitis. I could almost say the same for the tyrosine kinase inhibitor, which is sunitinib, also oral treatment, 37.5 milligrams per day. And here again, we performed a trial showing almost the same efficacy as everolimus, 5.5 months of PFS in the placebo arm, 11 in the sunitinib arm. Very few objective responses, stabilization of the disease in most patients. Here we have problems with patients with cardiovascular history or coagulation problems. And once again, quite a number of side effects, some of which are really non-comfortable for patients: diarrhea, nausea, hand-foot syndrome, asthenia in many patients, and some patients with very severe cardiotoxicity. So, once again, interesting if you do not have any options, but not so easy to use. Liver-directed treatments, very interesting, because most NET-associated liver metastases are highly vascularized by the hepatic artery. So if you disrupt the blood flow in the hepatic artery, while of course keeping the vascularization of the normal liver by the portal vein, you have a very good way of inducing ischemia in the tumors. This can be also accompanied by chemoembolization, intra-arterial chemoembolization, while we do not have a clear demonstration that there is an additive effect. This should be performed by experienced radiologists. I think you have experience of that, especially in other types of diseases such as CHC, which is much more frequent. 1 to 3 cycles, depending to response. Who are the good candidates for embolization? People with liver involvement significant but not major, 25 to 50% of the liver parenchyma. Those patients who have symptomatic and progressive liver disease. Of course, as you will not treat extrahepatic disease, this extrahepatic disease should be absent or limited. And as in most cases, the better the metastases are vascularized, the highest you can expect the response rate. Of course, this is very dangerous in patients who have portal vein thrombosis and should not be performed in those patients. Same contraindication, biliary anastomosis due to the risk of biliary abscess, bile duct dilatation. If the patient, but in the pancreatic tumors, it's very rare to have a carcinoid syndrome, this should be monitored very carefully. And you should be also very careful in those patients who have major liver involvement. It's not a strict contraindication, but in this situation, the experienced radiologist should probably do partial and sequential liver embolization. You should be aware that this is probably one of the treatments that give the highest response rate and symptomatic response rate, 60 to 85% symptomatic response. more than half of the patients with decrease in their chromogranin A and specific markers. Around 50% of the patient will get tumor shrinkage, which is very high, during 12 to 18 months. I will be very brief on SERT, which is not available everywhere, which is a radioactive micron-sized embolic particle loaded with Y90, yttrium-90, which is an intrahepatic treatment also delivering high irradiation doses to the tumors, which in our experience is performed in patients who are not eligible to embolization. It's not an embolization technique. It seems as effective as embolization. It poses problem of long-term toxicity of the radiation and also problems of costs. So, interesting in comorbid frail patients with bulky but limited liver disease. Last but not least, something very interesting is theranostics. Theranostics, you have a target, a vector, a chelator, and this allows you to target specifically a tumor. And of course here, the target will be the somatostatin receptor present in almost all well-differentiated tumors. You will link that to a somatostatin analog and to an isotope, in this case, which will be lutetium-177. So applying theranostic to NETs is quite simple. Looking first at overexpression of somatostatin receptors. Most of the patients do express them. Of course, PRRT will not be indicated in those patients who do not express them, but in the majority of patients who have on octreotide scan or gallium PET-CT an expression of somatostatin receptor, PRRT could be considered as an intelligent and targeted radio treatment. The major study that was performed studying the efficacy of PRRT with lutetium in patients with neuroendocrine tumors was not in patients with pancreatic tumors, but in small bowel tumors. It's NETO-1 study, and this study was extremely positive, as you can see, with a PFS that was not even reached in the treatment arm, while it was extremely short in the placebo, in the octreotide arm, which was the comparator, only 8 months of PFS. So this was the beginning of PRRT, and we do not have really available studies in pancreatic disease prospectively, but this is the Rotterdam experience. The Rotterdam group was really instrumental in developing PRRT, and as you can see in green, PRRT seems at least as effective, if not more effective, in patients with pancreatic neuroendocrine tumors with a median overall survival of 71 months as compared to patients with mid-gut tumors, 60 months. So there is a European approval of PRRT for patients with gastroenteropancreatic NETs, well-differentiated, unresectable or metastatic, progressive, somatostatin receptor positive. It's a treatment that is well tolerated if you respect some contraindications related to I would say, the white blood cell, platelets, and kidney function, and of course should be adapted depending on the figures of those parameters in any individual patients. To end, and to keep only the right part of this slide about pancreatic tumors, what can be the treatment decision in patients with metastatic pancreatic tumors? First, patients with non-aggressive disease, Ki67 below 10%, no symptom, slow growth. Start with somatostatin analogs. At progression, start chemotherapy most of the time with alkylating agent. TACE or TAE is an option, and PRRT could be a third-line option. In patients with more aggressive disease, Ki-67 over 10, symptoms, rapid growth, or bone metastasis, FDG positive disease, which is also a marker for aggressivity, start with chemotherapy upfront, alkylating agents or oxaliplatin agents. Everolimus, sunitinib are an option, as well as TACE in second line, and PRRT thereafter. In the minority of patients who do not express somatostatin receptors, chemotherapy first line and targeted agents as second line treatment. In patients with neuroendocrine carcinoma G3, cisplatin etoposide first line are the treatment option in second line but less effective. Take-home messages. Multiple systemic treatment options in those patients. Pre-treatment characterization is extremely important, but we have limited direct comparison, so probably the most important word, multidisciplinary team discussion to choose the treatment in national networks, clinical trials. We don't know exactly what was the optimal duration of treatments and if a maintenance treatment should be proposed. It's difficult to assess treatment efficacy because the classical RECIST criteria are probably not adapted to patients with neuroendocrine tumors. We are looking for combination treatments, sequences, but we fear cumulative toxicity, for instance, chemo plus PRRT. It's very important to have patient opinion to know its or her preferences, and this has an impact on decision making. And of course, as there is intratumor heterogeneity, temporal evolution, we should adapt treatment and change treatment according to tumor biology and repeat biopsies when necessary.